Hello, Nargiza.
Hello, good morning.
How are you today?
How are you? I'm fine. I'm much
Did you
better.
go to the hospital today?
Sorry?
Go to the hospital today?
No, today is off.
Nargiza?
Hello, good morning. Hello, good morning. How are you? I'm fine.
I have my.
Much
Did you go to
better.
the hospital? We have a YouTube on.
God, you have to switch it off.
There you go. Okay. This could be the start of a big project.
Mm-hmm.
You never know who's going to like this platform. You like this here? A little welcome in Russian.
Yes.
Of course I don't know Russian. My brother knows it, but I don't know.
There is one changes that has to be done next time. We have
Yeah.
to write 12 p.m. Moscow time, okay? Not noon time, so 12 p.m. because two misunderstandings happened. Okay, so
Okay.
East time 2:30 and 12 p.m. Moscow time, just for next.
It's 8 hour difference. No, 7 hour difference from Miami,
Yes.
Moscow. It's 8 hours in Taiwan, right?
Mhm.
Yeah. So, okay. Okay, I gotta do some last minute promotion. Excuse me.
Mhm.
Раз.
Hello.
Раз.
Да, здравствуйте, Виталий Сергеевич. Hello.
Здравствуйте, меня слышно, да?
Да, слышно.
То просто у меня компьютер пишет о том, что очень сложно ему включить микрофон,
Угу.
поэтому у меня пока возможно.
Все
Так,
слышно
у
очень хорошо.
меня в моей голове начало должно было быть чуть позже,
Да,
мне
я вот сказала
кажется.
уже.
Поэтому как бы это ваше счастье, что я вообще появился. Потому что я
Спасибо.
бы не появился, я бы ориентировался на арабские цифры, я привык к арабской бязи.
Да,
Вот.
видите, noon time мы еще не употребляем. Я уже сказала, чтобы в следующий раз мы писали.
Хорошо. Сейчас я донастрою тогда все системы, потому
Да,
что
я думаю,
меня нет в России, я сейчас на конференции, сейчас проводится большая конференция европейская, называющаяся ЯНС, Европейская ассоциация нейрохирургов ее проводит.
а вы в какой? В Барселоне вы, нет? Случайно?
Ну, я на пути в Барселону сейчас,
Да, потому что
потому что теперь не так просто становится добраться до Барселоны.
Мгм.
Так что да, завтра буду в Барселоне.
Супер. Мгм. Да.
Ну, теперь нужно просто на имеющемся компьютере сделать все то же самое. Мгм. Так, здесь. Мгм. Так, ладно. С этим будем разбираться потом. Мгм. Мгм. Так. А меня видно, не видно?
Пока нет.
Пока нет. Давайте попробуем настроить, чтобы меня было видно. Осталось понять, где это в веб-версии это делается.
Там
Так,
иконки в левом нижнем углу. Нет, не высвечивается видео.
это у вас, наверное, стоит же приложение Zoom,
Да. А, вы через
а у меня,
Google.
а у меня веб-версия стоит сейчас.
М.
Поэтому они немножко отличаются друг от друга. Так, допустим, если мы сделаем...
Всем привет.
Здравствуйте.
Андрей
Да.
Владимирович.
Меня видно, нет?
Пока нет, тоже вас не видно.
А мне интересно, у меня написано, что видео идет. Ну ладно, звук есть, самое главное.
Ага. У вас тоже нет вот этой иконки?
Нет, иконка есть, остановить видео. Я сейчас нажал, вот сейчас его как будто бы не должно быть видно. А сейчас нажал, оно и загорелась лампочка на ноутбуке, что якобы видео транслируется. А действительно видео нет.
Да, да, не видно.
Может, что-то в настройках еще у вас? Потому что я вот буквально вчера или позавчера вебинар
Да,
вел.
это надо Джона дождаться, он там, сейчас посмотрим.
Да, я позавчера вебинар вел, там меня видно было. Интересно. Кстати, а мы читаем-то на русском или на английском?
Ну, желательно, конечно, на английском, но
Ну
дальше
ладно.
уже вопросы, конечно, на русском. Это будет зависеть от аудитории, и если кто-то меня сейчас слышит, у нас 4 attendance, можно спокойно задавать вопросы на русском, писать их, вот.
Интересно,
Окей.
почему
А
меня
в
не видно?
следующий раз я думаю, что я бы хотела уже потом приглашать иностранных каких-нибудь гостей, ну и там уже будет на английском. В этот раз можно попробовать и на русском, и на английском. Вообще
Ну
у
ладно.
Джона несколько планов. Он хочет сделать вот эту трансляцию, где будет идти русским шрифтом перевод. Не знаю, получилось у него в этот раз, нет. Это очень поможет, конечно, нам всем. Второй момент, он создал такую штуку, как breakout room. Это когда докладчик заканчивает свою презентацию, если очень много вопросов возникает, можно параллельно перейти в другую комнату.
Мгм.
Те, кто хотят, идут к докладчику, задают ему вопросы. Тем временем второй докладчик уже, чтобы не терять время, начинает вести свой
Слушайте,
диалог.
надо разобраться все-таки с видео, почему меня не видно. Хотя, в принципе, не обязательно меня, чтобы видно было, но... А, кстати, а демонстрацию экрана давайте сразу сейчас попробуем, получается или нет демонстрация. Сейчас я демонстрацию. Ну, как видно демонстрация?
Да, окей, sharing the screen. Ага, все, самое главное, что...
Это самое главное, даже если... Так, а как выйти из демонстрации тоже?
Stop sharing может быть.
Согласен.
Да, у меня на русском приложение.
Окей. Остановить демонстрацию, нет? Или как там?
Да, нет, новая демонстрация. Пауза демонстрации, наверное. Что, ушло? Демонстрация не видно ее теперь?
Нет, не ушло. Там
Не
же.
ушло. Приостановлен. Остановить совместное использование. Вот как это называется по-русски. Так, что же делать? Может переподключиться с учетом
Ну,
того,
давайте, да, оставьте.
попробую переподключиться. Может быть, видео появится.
Подскажите, пожалуйста, относительно регистрации.
Да,
Она,
и-
возможно, только сегодня до 12 часов, или потом тоже можно будет зарегистрироваться пользователям знакомым.
пока идет вебинар, можно зарегистрироваться, да, спокойно.
Мгм, хорошо, спасибо.
И там еще есть трансляция на YouTube автоматически, поэтому если кто-то хочет просто смотреть, он может идти на ссылку в YouTube. Вот.
Нет, Наргиза, видео почему-то нет.
А сейчас Джон придет, спросим его. Я не знаю.
Нет, я думаю, что с моим ноутбуком может быть связано или с версией приложения. Она сейчас только что обновилась перед запуском, попросила обновления. Вот обновилась и ничего не показывает, кстати.
У меня-то вопрос стоит, что я даже демонстрацию запустить не могу, потому что у меня, я уже и приложение поставил, он пишет, что это бета-версия.
Может быть, бета-версия установилась.
Да, может быть, из-за вот этого. Ну, а вот то, что идет в варианте, так, где она? В варианте онлайн-версии, здесь только есть чат, звук и все, и больше ничего.
Только
То есть варианта того, что...
получается для слушателя.
Да, да, как слушатель получается точно.
Поэтому-то надо...
Ладно, ждем Джона.
Да.
Да, я боюсь, что он не
Ну, в крайнем случае,
IT-специалист,
Виталий
и
Сергеевич,
точно не решит.
если что, мы
Да.
перенесем на другой день.
Да, это тоже не проблема.
Я думаю, что я-то могу, в принципе, прочитать доклад, так как у меня демонстрация работает, но нет видео, ну и хрен с ним. Будем представлять, как я выгляжу.
Ну, я пока нарисую. У меня есть
Да, да, да.
карандашик.
Да, вот. Ну и все. Ну, я думаю, если Джон не решит этот вопрос.
Мгм.
Я думаю, что он не решит его.
Кстати, Виталий Сергеевич, у вас 17 во сколько начало?
17-го, да я там с утра, с
Представляете, как я
9:30.
выгляжу.
Мгм.
Не слышу.
И сейчас Андрей Владимирович придет.
Включился, да?
Мгм.
М. Надо было. Ой. Мгм. Мгм. Так. Уже понял.
Кстати, Наргиза, возможно, знаете что?
Мгм.
Там права докладчика меняются. Посмотрите мои права на демонстрацию видеоизображения. Может быть, что-то там с правами.
Я тоже здесь не самый главный человек. Видимо, Джон это все решает, потому
Да.
что я вижу только participants, chat, share screen, record question, resident, apps, upload. У меня нет доступа к каким-то дополнительным опциям.
Кстати, Виталий Киселев числится как участник. Может быть, поэтому?
Да, есть участник, панелист.
Нет, нет, я вот числюсь как докладчик.
Все,
Соответственно,
значит, сейчас, Виталий Сергеевич, сейчас мы сделаем вас как докладчика. Секунду.
Мгм.
ну, я как говорил, у меня минут 35 примерно займет, 40, может быть, даже.
А, Виталий Киселев, participant. Talking permitted. Так, панелиста у нас 3. Окей, да, его сделать надо панелист. Сейчас. И Алексеева Ивана. Сейчас, секунду.
Oh, you can let them in.
John.
Yeah, let me make you co-host. And you can let the people in. Let me show you here.
And
And you get to learn. Okay, now you're co-host. And you can admit the people you want to admit.
1 second. More. Disable token. Promote to panelist. Мгм. Вот, Виталий Сергеевич, я вас направляю в панелисты. Дайте согласие.
Were you able to admit them?
Получилось, Виталий Сергеевич?
Да вот смотрю, сейчас слышно меня, да?
Да, сейчас вас слышно.
Подключить в качестве.
Ага, дан. Нет, ждем вас в панелистах. Ага, 4 панелиста теперь. Отлично. У вас теперь получилось? Есть там sharing screen? Другие функции?
Сейчас меня слышно?
If
Сейчас
anybody
слышно, да?
wants to practice, now's the time. Screen
Мгм.
sharing. Okay, Nargiza, if anybody wants to practice screen sharing.
Yes, we are trying. И нам осталось еще... we are waiting for Алексеев Иван. Так.
Мгм. Так. Вот.
Don't be afraid to crack the whip, Nargiza.
Ну,
Get that vote.
Нелли, так,
Видео запущено, но оно не показывает.
не показывает.
То есть у меня появилась демонстрация экрана. Ну вот, допустим, возьмем сейчас. Я хотел поделиться. И есть, да, демонстрация экрана?
Да, все, мы видим вашу презентацию. Ура!
Так, с этим хотя бы хорошо. Так, сейчас, секунду. Теперь вопрос Так, это остановить. Где она у меня?
Внизу.
Сейчас отключилась, нет?
Нет, пока не отключилась.
То есть так и продолжает, да?
Мгм.
А вот, все вижу. Теперь ушла?
Ушла.
How is everybody doing? Dateme Malako.
Everyone is fine. I
That's-
guess so.
That's all I know how to say is pass the milk. Because my brother was very unusual. In high school, he took Russian, which no one took. I mean, he was one of the few students in the class, but
Мгм.
he was serious about, he was in high school. He used to come home at the dinner table and teach us words. It was quite fascinating. And I'm going to try to get him involved. You met him.
Yeah. Where is he now? Is he having some work or what?
Yeah, I just text him. It's late in Hawaii. It's like, well, for him, for regular people, 11 o'clock at night is late.
Oh, yeah.
They don't go out at 11 o'clock. Forget it.
You know,
So-
John, one more issue. We have 2 of our panelists. They are not able to be visible. Okay.
Be what?
Visible. We are not able to see them, even if they switch on the camera.
Okay, let's work on that. Which people?
Андрей
need-
Туполой and Vitaly Kiselov, 2
Okay.
of our panelists.
First of all, you don't have to have your picture to present a PowerPoint. You know that, right?
Yes, the PowerPoint sharing screen is working, but just the video is not working.
Okay, they need to click on the icon of the camera.
They clicked.
Yeah, can you do that, Natalie?
My camera is working now.
Yeah, you can use the, tell them to click on the icon.
It's
Of the-
on. The icon is on, but
Icon is on.
Okay, reboot, get off, leave the computer, turn off your computer completely.
Okay, turn off completely.
And come
Okay.
back. And come
Thank you so
back.
much. And come
Completely.
back a few minutes later. Okay.
Yeah, we wait. And anybody else, Vitaly Kaselev needs to, okay, whoever else needs the camera needs to reboot. So your system recognizes your video platform, or it's open. Normally, after a daytime, people look at various platforms, Facebook, this and that, and then they get to a webinar, and it's not hooked up to Zoom, it's hooked up to another video platform. And
okay.
if you reboot, that refreshes everything. It starts anew. I know you neurosurgeons can understand that.
We can. One
Okay, does anybody else have a problem with the camera? Because we can try to fix it. Now's the time to fix it. And the first step is to reboot and come, but we'll wait for you. Now, Giza, does anybody else want help with the camera? It's not totally necessary to put your camera on. It's okay if you can't figure it out. As long as we can see your PowerPoint. Are there any presenters, Giza, that need their camera turned on?
One more presenter, but Vitaly Sergeyevich, Dr. Vitaly, better to stay.
Yeah, could you
Okay.
ask them to try to turn the camera on, please? Okay,
My camera
Andre-
is
Andre
turned-
Dubovoy, I think, has his
Yes,
camera working.
John, my camera is turned on now, and I
Okay,
show the camera is turned on, but
Yeah.
I don't view my video.
You're not visible, yes, still.
Yes,
So-
yeah. Again, Andre, turn off your computer completely. Leave the Zoom.
yes,
Yeah,
I'm
John, we left it. He did it 2 times. It is not
Oh,
working.
really? Oh, okay.
Mhm.
Okay,
the LED light is lighting on my laptop.
That yes, a video is going, but he is still not visible. So
okay, maybe you
I
need
think
to.
this is not very big problem,
yeah,
but I have a good demonstration of my screen, and I will read my presentation, and
Yeah,
I have a good voice.
okay, okay, we can try to fix your camera. Have you downloaded Zoom lately? Have you had the latest?
he just recently downloaded the Zoom, not
Yes, yes.
downloaded, renewed the app.
Okay, does your camera work on other platforms? Does your camera work on?
No, I think no.
Oh, okay, so your and your other platforms, it doesn't work either?
Maybe I'm not going as registered participant, I think.
Your camera, according to me, my dashboard, your camera is on.
Yes, and my desk shows my camera is on too.
Yeah, did you check it to wipe it off? Maybe is there a tape on it or something?
We don't know.
This is a program mistake, I think. Mistake in a new version of Zoom, I
Yeah,
think.
Vitaly's the same. That camera is, yeah, your camera is off,
Yes.
Vitaly. I see your voice is on okay. See, you can admit people. Do you see the people you need to be admitted?
Yeah.
Is anybody in the panel that needs to be admitted?
Okay, Иван Алексеев, more, promote to panelist. Я вас добавляю в панелисты.
Can you let them in?
Yes.
Okay.
Nargiza, it's time to start now.
Yeah, we can start. Just one
It's
second.
noon
Yeah, okay.
already.
You ready to start? And I'll introduce you first, Nargiza.
1 second. Let us, one panelist will be rejoining webinar as a panelist. He has to, okay. We are waiting.
Okay, who needs to come in?
Okay, let's start. I hope.
Oh, okay. I'll introduce you and then you take it from there.
Yes.
It's going to be in English, right?
Yes, it's going to be in English and the questions can be in Russian, okay?
Okay, yeah, if you need to use Russian, that's fine. Fine. You can always help them. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from beautiful Miami Beach in Florida, the home of Neurosurgical TV. We are honored to be hosting the Russian Neurosurgery Grand Rounds with host Nargiza Sartova. She's a neurosurgeon from Uzbekistan, currently in Turkey, taking pediatric neurosurgery, and she put this together. Thanks a lot, Nargiza, and it's all yours.
Good morning, good afternoon, and good evening, everyone, whoever is there. It's an honor to be here today. Today's kind of historical moment. We are starting big project, Russian Neurosurgical Grand Rounds, and today I would like to introduce one of the biggest neurosurgeon in Russia, Dr. Andrei Dubovoi, the leading neurosurgeon from Ilyinskaya Hospital in Moscow, who specializes in on treating the patients with space-occupying lesions, mostly
recording in progress.
Vascular. Can you
That's okay.
Stop on video.
Okay, have you finished introducing him?
Yes, and Dr. Andrei Dubovoi is a member of WFNS Complications Committee, ACNS Education Committee, Care Committee, member of ACNS. So today's presentation is going to be bypass techniques in complex posterior circulation aneurysms case report. Dr. Andrei, please.
Thank you, Nargiza. Thank you, John, for inviting me as a lecturer at this Grand Rounds in Russia. One second, I try to share my screen. Can you see my screen?
Yes, perfect.
Okay, thank you so much. Good afternoon, dear colleagues, dear friends. Now I work in Moscow in Ilyinskaya Hospital, which is a private hospital. But the material presented in these presentations is from my former place of work in Novosibirsk Federal Neurosurgical Center. Today, I will present to your attention a rare pathology, complex aneurysm of the vertebro-basilar territory, which had to be treated with revascularization. There are two main options for revascularization, ECIC and ICIC bypasses. As is known, the level of evidence for revascularization in treatment of complex aneurysms is rated at 4, and a grade of recommendations is rated at C. Let's look at the options for revascularization. EC-IC bypasses. As a donor, we can use a low flow vessel, STA. For example, STA. STA bypass can be single barrel or double barrel. In cases when we use for revascularization as a donor internal maxillary artery, we can perform middle flow bypass. And of course, high flow bypass, as a donor, we can use external carotid artery and another big arteries on the neck. IC bypasses can be four types. First of all, reanastomosis, when two ends of arteries connected together, and another type, reanastomosis with short interposition graft, reimplantation, end-to-side fashion, and bypass in situ, side-to-side fashion. The necessary equipment for the operation room for revascularization for aneurysm should include microsound Doppler with small probe around 1 millimeter, maybe 2 millimeters, with resonating and at the 16 or 20 megahertz, and using for detecting the flow inside the vessels in the brain. And of course, ultrasound flow meter. You can see the Charbel probes for this flow meter. This device can use for detecting the volumetric blood flow inside the vessels and inside the bypasses making in patient. And of course, your microscope can be used in a very nice option as ICG video angiography. A few words about preparing the patient for revascularization. 5 till 7 days before bypass surgery, the patient should start taking aspirin 100 milligram per day. On the day of surgery, a platelet aggregation test is performed on the patient. You can see the platelet aggregation test with 3 inducers, but we interested only ASPI test activated by arachidonic acid. This patient has a result as 20 units and good values for aspirin treatment up to 30 units. This patient is ready for revascularization. And the patient should continue taking aspirin for at least 3 months after surgery to achieve a good endothelization of the anastomosis area. I want to present our interesting cases for your attention. First case, complex circular fusiform aneurysm located in vertebral artery junction with transition to basilar artery trunk. I can use IC pica bypass in situ in this case. Male, 54 years old. You can see aneurysm located and in VA junction, and left pica coming from aneurysm dome. You can see pica coming from the dome of aneurysm. This is a scheme, a picture of vertebro-basilar region of this patient. You can see left vertebral artery, right vertebral artery, aneurysm, and pica coming from the left. Left pica coming from the aneurysm, and right pica coming from the right vertebral artery just before the aneurysm. You can see intraoperative video. I checking the approximation between 2 caudal loops. This is right caudal loop. This is left caudal loop. Aneurysm located at the left side. You remember that. I closing both of pica loops using 1 temporary clip, and distally I closed picas not together. Each pica I closed by using a temporary clip. I marked the picas, both sides of medial walls. Then I perform incision along the middle wall of the left pica. The length of this incision around 2.5 or 3 diameters of the artery. After that, I make an incision along the middle wall of the right pica. The length of both incisions on both picas can be equivalent. And then I making a posterior wall of my anastomosis using a continuous running suture. I use 10 zeros nylon suture. Now I try and knot after suturing the posterior wall and tighten my posterior wall anastomosis. After that, I flush the lumen of the bypass and check the quality of posterior wall bypass, and starting suturing an anterior wall of the bypass. This is fastened video, 10 times fastened for suturing of anterior wall. Okay, I'm ready to tighten last knot, and I'm start a flow through the bypass, and then bypass is ready, and then I perform ICG video angiography. You can see good patency of bypass and good feeling all small perforators on the medulla and cerebellum. After that, we perform DSA. After making bypass, you can see good feeling both picas through the pica side-to-side bypass. And you can see the diagram of this first part of our surgery, pica bypass between two caudal loops of both picas. After that, the patient was transported to another operation room, to the endovascular operation room, and the flow diverter was implanted into the left vertebral artery. And now the flows coming from the left vertebral artery through the flow diverter to the basilar artery trunk and to the PCAs. Now you can see the second stage of our surgery. DSA implanted into the left vertebral artery, stagnation of the contrast inside the aneurysm cavity, and after that, our endovascular surgeon perform endovascular coiling of aneurysm cavity and initial part of left pica. You can see the diagram after making second stage of our surgery. This is flow diverter. This is coils inside the aneurysm. This pica was compromised, but both pica territories filling through right pica. Through the right pica, you can see at this slide, and right pica feel not only right pica territory, but through the bypass feel a left pica territory too. This is MRI after making PCI pica side-to-side bypass, and after FD implantation and aneurysm coiling. The patient feels good. Next case, complex saccular fusiform aneurysm of the lateral medullary segment of the right pica. I perform right pica end-to-end anastomosis, ICIC bypass. You can see female, 61 years old. She was treated in another country she underwent endovascular coiling of the lateral medullary segment aneurysm of the right pica, but she has not controlled DSA after surgery. 3 years after surgery, she performed DSA, and we see the part of aneurysm filling and coils inside the aneurysm, not closing all the aneurysm cavity. This is fastened video. I open the cisterna magna. You can see the coils outside the aneurysmal cavity. I detaching the aneurysmal dome from the medulla, from the caudal cranial nerves, and then I try to clip in the neck of the aneurysm. But after clipping, I checked the flow through the pica, and the flow is not good. I decided to open aneurysm cavity and removing coils. I use my big scissors for cutting platinum coils. I'm cut off aneurysmal dome, remove last part of coils. You can see small part of aneurysm. This is a neck part, and I try to clip the neck again, but the flow is not so good because the neck consists fibrosis. I'm trying to lavage the aneurysmal cavity, dissect the wall of the aneurysm to prepare the aneurysmal neck for suturing, and using 9-0 nylon, I suturing the neck part of aneurysm. Starting blood flow through the pica, but flow is coming not so good. I decided to resect the aneurysm and to reconnect both ends of pica between together using end-to-end fashion 10-0 interrupted nylon suture. My bypass is done. I'm starting blood flow. You can see a good feeling of the pica and good flow detected by ultrasound Doppler. You can see DSA surgery next day. You can see left pica, right pica, I'm sorry. And you cannot see the anastomosis line because the pica feels good. Next case. Complex aneurysm left V4 pica origin aneurysm. I use a bypass in situ, pica side to side ICIC bypass. Female, 35 years old. The aneurysm located at the left pica origin. Aneurysm was circular fusiform shape, and the left pica coming from the aneurysm. First of all, I tried to apply clips along the neck of the aneurysm. The neck is not very long, and I think is not very bad that I only use clips without bypass. But after clipping the flow through this bypass, through this artery is not so good. I decided to perform pica bypass between two caudal loops. You can see right and left caudal loops of the pica. I perform this side-to-side bypass, and then I trap the aneurysm neck without any complications. On the control DSA and control CTA after surgery, you can see good feeling both picas, territory. Next case, complex aneurysm of the single right pica aneurysm. I use IC bypass in situ between the loops of the same artery. This is very interesting case. This man, 41 years old, he has not left pica. He had only a right pica coming from V4 segment of the vertebral artery, and this single right pica has an aneurysm located in the lateral medullary segment. I try to use air revascularization method. You can see the two loops of pica, one caudal loops, and origin of the pica coming very close together, very close in this point. I decided to perform side-to-side bypass between two loops of this single pica, between origin in lateral medullary segment and between caudal loop of this pica. And then, after making a bypass, I trap the aneurysm. And now the flow coming through the vertebral artery to the origin of the pica, then through the bypass, the blood coming to the distal part of pica, and aneurysm successfully treated. You can see DSA next day after surgery. This bypass working good, and both pica's territories feels good. You can see. Next very interesting case. This is case of giant partially thrombosed aneurysm with compression of the brain stem. This aneurysm located in V4 segment of the right vertebral artery with transition to the basilar trunk. In this case, I use extracranial, intracranial high flow bypass. As a graft, I use a radial artery. Initially, patient come to me of the aneurysm. You can see giant aneurysm located in the right vertebral artery with transition to the basilar trunk. The size of the aneurysm was 23 and 20 millimeters, and the patient don't want to operate it at this time, but 6 months later he's coming again, and we detect that the aneurysm was enlarged in diameter, and brainstem compression symptoms already the patient has had fourth nerve palsy and choking. And now MRI and CT angio shows the aneurysm size was 31 and 36 millimeters. We decided to operate this aneurysm. You can see DSA before surgery, frontal and lateral projection. This is a small video of the first stage of our surgery. You can see tentorium. This is a left side subtemporal approach. Using a diamond scalpel, I cutting tentorium with protection of the fourth nerve. I protected a fourth nerve using a catenoid. You can see brainstem. This is a fourth nerve, and this is superior cerebellar artery. This is fourth nerve. I'm mobilizing all the fourth nerve. This is CA, superior cerebellar artery. I'm harvested the graft, radial artery from the left hand of this patient, preparing the graft as a fish mouth. I'm marking the edge of the fish mouth. And then I'm matching the recipient artery and the graft. The recipient artery was around 1.5 millimeters, and the graft was around 2.1 millimeter. I'm marking the SCA and closing the recipient SCA. The closing distance around 1 centimeter. Then I'm making a hole inside the SCA and make a long incision along the closing segment. The incision length around 4 millimeters. Flush the recipient artery and making a bypass using two continuous suturing for one suture for one side. The first suture on the heel of the anastomosis. I'm fastening this video. After making a first suture, I checking the quality, opening the anastomosis line, flushing again, and making a second continuous suture on the another side of the anastomosis. After that, anastomosis is done. This is a distal anastomosis, and I'm starting a blood flow. You can see good filling of the radial artery. After that, I'm close this radial artery, flush it, and make proximal anastomosis between external carotid artery. I'm checking the blood flow through the superior cerebellar artery. The flow comes good. You can see bypass. After making and starting blood flow, then patient was transported to the endovascular operating room, and endovascular surgeon performed occlusion of the right V4 segment just before coming into the cranium cavity. You can see DSA after surgery. You can see good feeling of this bypass. This is lateral projection and good feeling both vertebro-basilar territory, and this is a frontal projection of DSA. Next day after surgery, we perform a CT angio. You can see good feeling of the basilar artery trunk through the bypass, and you cannot see the aneurysm cavity. You can see high flow bypass coming from external carotid artery inside to the SCA, and the patient symptoms was regressed. He had a regressed reduction. He has regressed of false nerve palsy. 1 year after surgery, the patient sent a video he has a good feel, good healthy. And MRI shows not aneurysm visible of this patient. Aneurysm was disappeared. Next interesting case, recurrent spica aneurysm after coiling. The aneurysm located in the origin of the left pica. I have a reimplantation of the left pica to the right pica and to side fascium. This is 12 years male with fusiform aneurysm located at the origin of the left pica. This aneurysm was bleed 8 months ago, and patient underwent a surgery, endovascular coiling in another city. This video shows you caudal loop of the right pica. This is a left vertebral artery. This is aneurysm dome. This is a pica coming from the aneurysm. This is a left pica. This is aneurysm dome. I tried to visualize all aneurysm. Temporary, I closed vertebral artery and tried to attempt to placing a first clip to the neck of the aneurysm, checking the blood flow in the left pica and aneurysmal dome. In the aneurysmal dome, the flow is not detected, but in pica the flow is good, but not very good. I decided to remove thrombotic masses from the aneurysm and readjust the clip on the neck of the aneurysm. I opened an aneurysm, and you can see the thrombotic masses removed from this aneurysm. And after that, I decided to removing of the aneurysmal dome. And after removing the aneurysmal dome, I'm placing another clips on the aneurysmal neck. In this case, I use a bayonet clip. I'm trying to release first clip, but you see the bleed from the neck of the aneurysm, because the neck was with small rupture. I am closing V4 segment, removing first clip, use hermetization of the hole near the neck of the aneurysm using tachocomp. Then I start a blood flow through the V4 and pica and try to detect the flow through the left pica. The flow is not so good, and I decided to clip the aneurysmal neck together with pica together. I am compromised the pica flow now, and I decided to use a pica bypass. I'm close the left pica. I marked the right pica, donor side, and cutting off the left pica. Flush the lumen of the pica, of the left pica. Prepare for suturing using a fish mouth and marking of the edges of the left pica. Placing a first stitch, closing the right pica using micro clips. After that, I open a right pica. I make an incision along the right pica around 2 diameters. flush the lumen of the right pica, and then I make an anastomosis, tighten the first knot. I make an anastomosis using side and end-to-side fashion, end-to-side. This is a reimplantation of the left pica to the caudal loop of the right pica. Making a second knot on the heel, on the toe, sorry. And then perform interrupted suture on the both sides of the anastomosis. I am start a blood flowing through the anastomosis. And try to check the blood flow. The flow is good, and aneurysm was excluded from blood circulation. At the last, I want to reduce the volume of the coils inside the aneurysm. You can see a left ICA injection, pica not contrasted, and right pica injection, right vertebral artery injection shows the filling of the both pica territories. You can see control CTA after making a bypass reimplantation. Next, fusiform pica aneurysm, lateral medullary segment of the left pica. I use the reimplantation of the left pica to the left vertebral artery by using end-to-side fashion. You can see fusiform aneurysm of the left vertebral artery pica junction and pica loop coming from the aneurysm. You can see this pica loop coming from the aneurysm. This is a man, 65 years old. This is DSA before surgery. You can see the aneurysm around 11 millimeters. And if you look to this picture, you can see the small part of pica around 2 millimeters. This is a healthy part. And then we see the aneurysm, fusiform shape aneurysm, and the pica, distal pica coming from the aneurysm. This is small video. This is aneurysm, vertebral artery, left pica coming from the aneurysm. This is proximal part of the pica. I'm trying to visualize V4 just after the aneurysm, distal V4. Initial, I clip the neck of the aneurysm with origin of the pica. Then I'm cutting off the left pica from the aneurysm. Flush the lumen. Prepare the end of the artery by cutting off using 45-degree cut. Marked the edge of artery, and then I try to close V4 segment and open V4. The wall is very thin. Is very thick. It's very thick. Sorry. I'm open, making a hole inside the artery, then flush the B4 segment and making an anastomosis end-to-side fashion using using 9 zeros nylon suture. After making a bypass, I'm starting blood flow through the V4 and checking the flow is good through V4 and through the pica. Pica was reimplanted to another. You can see reimplanted pica to the V4 segment. You can see pica coming from V4 and aneurysm excluded from blood circulation. This is MRI after making bypass and closing aneurysm without any complications. Giant fusiform aneurysm located in PCA and P2 segment of the right PCA. In this case, I use STA P2 PCA low flow bypass and two-side fashion. You can see giant aneurysm with brainstem compression. This aneurysm located at the P2 segment of the right PCA. You can see CT angio before surgery, giant aneurysm. This is a distal part of PCA coming from the aneurysm, from this fusiform aneurysm. And this is proximal part, P1 segment. This is subtemporal approach. I'm cutting off the basal vein. You can see the brainstem. This is an aneurysm. This is an aneurysm. This is tentorium edge. I'm preparing the aneurysm and the P2 segment for my bypass. I'm harvested STA trunk, prepare it, making a bypass, making a fish mouth and marking. Try to detect volumetric blood flow through the P2 segment, marked P2 segment, then isolated of P2, and I'm open P2 using insuline needle, making a hole in the arterial wall, but you can see the bleeding, a small perforated, need to be closed. I'm close a small perforator and making arteriotomy around 2 diameters of this P2 segment, flush the lumen of the artery using heparinized saline and making a first stitch. Tighten the first knot on the heel, second my stitch on the toe, and then I'm making 2 interrupted sutures on the both sides of this bypass. Starting blood flow. You can see STA, ICG video angiography, good feeling of the STA and P2 segment with perforating arteries, checking the Doppler, and I use ultrasound flowmetry to compare the volumetric blood flow before and after surgery, and perform distal occlusion of the aneurysm. After distal occlusion, I perform ICG checking of the bypass. You can see good feeling of the bypass, good feeling of the arteries of the brainstem, and you cannot see the aneurysm. Aneurysm was dark. This is CT angio just after surgery. You can see STA coming to the P2 segment. And this is 3D CT angio. You can see STA coming into the cavity of the skull. This is STA. This is clips just after the aneurysm, and aneurysm is not visible, not feeling. And conclusion. Mastering the technique of creating extra intracranial and intracranial bypasses will expand the possibilities of neurosurgeon in treatment of complex aneurysms, including the vertebrovascular region. However, this method needs a high demands of microsurgical skills of neurosurgeon, as neurosurgeon need to work in narrow and deep spaces, for example, in posterior fossa, with tight time constraints. And intracranial bypasses ensure sufficient blood flow in the recipient artery territory that confirmed clinically and flowmetrically. Thanks for your attention.
Thank you very much, Dr. Dubovoy, for your extremely interesting and really difficult presentation, because for us as for young neurosurgeons, it's not easy to understand how to handle it. And you showed really nice and beautiful cases. It literally requires patience, meticulous work, and deep understanding of the anatomy. So thank you very much. I would like to ask few questions. What suture material do you use? Most of the time, is it 9-0 or do you require 10-0 or 8-0?
It depends. Okay, thank you so much. It depends of the thickness of the arterial wall. In most cases, I use 10-0s, but if I suture the pica to vertebral artery, I use 9-0 because the vertebral artery wall is more thicker than the picas wall, for example. And sometimes I use 11-0 if I suture perforating arteries with very, very thin wall.
Okay, thank you. And another question, how long do you keep your patients on anticoagulant therapy after surgery? How many months?
I never use anticoagulant therapy. I use only anti-aggregant therapy, antiplatelet therapy. Because no need to use anticoagulants if you perform bypass correctly. But antiplatelet therapy, I prefer to use around 3 months after surgery to achieve a good endothelization of the bypass area. And after that, you can, the patient can maybe to stop
taking these drugs. Okay.
Yes.
Okay, understand. Thank you so much. I just want to give one more comment that Dr. Andrei Dubovoy has really huge experience in neurovascular surgery. He has done around 2,000 aneurysm cases. Out of that, 450 bypass, high flow, middle flow, and low flow bypass. So he's really experienced surgeon, and I'm very glad that back in 2019, I was your student, I was your resident, and I had a really great experience and chance to learn from you. Thank you so much.
Thank you, Nargiza, for your comment. Thank you.
We can go for our second participant. Can I introduce John?
Excuse me, we have another question. Abdusami Portsaev, could you call on him, please?
I have a question. Yes, please, Abdusami, you can ask your question.
Go ahead, Abdusami. Or you can text it.
You can text your questions and we will come back to it.
Or you can ask it. Oh, there you go. Okay.
My name is Igor. I work in the center, Moscow. Question to Dr. Dubovoy. What did you do if pre-op aggregation assessed by aggregation test is not optimal?
Oh, thank you, dear Ilya. It's good question. This is good question. If the aggregation test is not optimal, I give to patient aspirin increased in twice, not 100 milligram, but 200 milligram before surgery, and it needs to use couple of days to achieve a good parameter of aggregation test.
Okay, thank you. Any other questions? So the question from Dr. Abdusami Porsaev. Kindly tell me, please, do you do 4D MRI angiography before surgery to assessment of blood flow?
A good question, but we have not 4D MRI in our clinic, and I never use 4D MRI angiography before surgery for assessment blood flow.
Okay, thank you. So for the second question from Dr. Ilya, is the aspirin is not working, what medication do you use?
Good question. If the aspirin not working, you can use a bypass option, but you should to make bypass very nice, very correctly, because if you have any mistakes, your bypass may be compromised and was to thrombosed. You can use your surgery if the aspirin not worked in patient.
Thank you. Any other questions? I think done. So if anyone has questions, okay. Ilya Molchanov, Dr. Ilya Molchanov has the question. Which variants of craniotomy were selected for your operation?
It depends of the location of pathology. If you have an aneurysm located in P2 segment, for example, you can use subtemporal approach. If you perform a revascularization between picos loops, you can middle suboccipital approach. If you switching around the V4 segment of the vertebral artery, you can use far lateral approach. It depends on the pathology.
Okay, thank you. It's really interesting question. Okay, we have the questions from the. Okay, done. So, can we go for our second?
Sure, Andre, we'll see your face the next time when you fix your camera.
Maybe.
Thank you very much. Thank you very much.
Thank you, John. Thank you.
So I would like to introduce our second participant. I would like to say this to this world. One of the best endovascular neurosurgeon in Europe, in Russia, in the world as well. So Dr. Vitaly Kiselyov, MD, PhD, one of the leading endovascular neurosurgeons in Russia, who is currently practicing in Leningrad Regional Clinical Hospital. Dr. Vitaly Kiselyov also has a really huge experience in endovascular treatment of neurovascular pathologists. He is the active member of European Association's Neuroradiologists, European Association of Neurosurgical Surgeons, and Russian Neurosurgical Society. So we are very happy to start listening to your presentation, Dr. Vitaly. Hello.
Can you hear me?
Yes, we can.
And do you see my presentation?
Yes, we can.
Okay, let's start. First of all, I'd like to say thank you for organization of this meeting. I think this is can be the first step in our long road to the knowledge to their knowledge in neurosurgery and endovascular surgery. So I think this can be very, very interesting for us. So my presentation is not so scientific like my colleague Andrei, but I want to tell some features and talk about results of endovascular treatment of ophthalmic segment aneurysms. So today I think that the endovascular treatment for this localization of aneurysm is more better than open surgery. So I want to show you some features here, and maybe you will agree with me. So ophthalmic segment aneurysm occur approximately in 5% of cases. There are more frequent multiple lesions of the segment, and this localization we very often have the tandem aneurysms. They represent technical difficulties for macrosurgical operations due to their locations in relations of clinoid processes, makes it difficult to descend the neck of aneurysm. There is no proximal control of the artery. So endovascular surgery should be considered as the first choice method for ophthalmic segment aneurysm. So the purpose of this presentation was to select the optimal tactic of endovascular treatment of patients with aneurysm of ophthalmic segment of the internal carotid artery. So this is anatomy. Anatomy, this is the base of our work. If you don't know the anatomy, so I think you can't operate this patient. So you need to understand that ophthalmic segment is very short segment of the artery. So it's begin from the internal ring and to the posterior communicants artery. So in this location, soon will be another slide where I show you that we have only 4 typical localization of aneurysm, which are dependent from the artery who arise from this segment. So here you may see the anatomy. You need to know its rules. So in the Department of Vascular Neurosurgery, 96 patients with aneurysm of ophthalmic segment of ICA was treated by endovascular method. The average age 49 years old. So, and how you may see, the female is more frequent to occur the aneurysms in their brain vessels. So that slide about I talked. This is typical localization of aneurysm of ophthalmic segment. You may see the main localization, which 1A. So the second is 2A, and 1B and 2B are rarely than the first A and second A. So they depend from the ophthalmic, only 1A localization are depend with ophthalmic artery. Sorry. Are you hear me? Yes? Can I continue?
Yes, we can hear you.
Okay, let's go. So, aneurysm localization of the segment, like this classification, 1A type more most frequent, 31 patient, then 1B, 2A and 2B. So the size of aneurysm was less than 15 millimeters. So we have more frequent this middle size from 6 to 14 millimeters. So this is the more frequent size for this localization. And in 42%, I think it's a lot. We had a multiply lesion of this segment. 90 patients had tandem aneurysm, so of one segment, and 16 patients had multiplied aneurysm in other localizations. So you need to have the tactic to treat this aneurysm by one session or maybe 2 sessions. So you need to find the decision how you will treat this patient, because this amount is too high, 42%. It's a very huge number. So the manifestation in this group was in most frequent without specific symptoms. So 34% were had headache, 15% had vision lesions, no specific symptoms. It's I think for this patient it was were surprised, because they went to MRI and found an aneurysm. So, and only 13% of the patient had SAC. So you need to understand the structure to understand that most of these patients will come to you without acute stage of hemorrhage period. So preparation condition of this patient we evaluate by modified ranking scale. So I need, for my opinion, you need to understand what your treatment did with patient, because most of the some of the patient had a problem before your treatment. So, and you need to understand the problem at the end of the treatment depend of your treatment, or they are depend of the condition, pre-operation condition of the patient. So in this slide, you may see that most of people, of patients, had a very good condition, MRS 0-2, and to understand that all of these patients in this group was in good condition before we started to treat them. So our result, we performed 111 aneurysm. So in 7% we use coils, in 16% we use assistant technique, coils and balloon. In coils with stent we use in 15%. So you may in 4 situations we combine coil, stent, and balloon. So how you may see, the assistant technique is approximately 33%. So and the very modern option, I think it's a revolution in treatment of aneurysm of this localization, is flow diverter stents. So this is not a stent, this is device. This is device who help you to occlude the aneurysm without any working. You need just to deploy the stent. You need to deploy the stent correct in the vessel. So, and soon you may have a result. So this is revolution, I think, in endovascular surgery. And how you may see, only 8 patients, only 7% of patients with this localization you can treat with coils. It's very low rate, very low rate. So it's talk to us that the most of these aneurysm are complex. The most of aneurysm have a rising branch from the neck of aneurysm. Most of aneurysm have not good geometry, tandem lesions. So, and in these cases, you can't use only coils. You need to use assistant techniques of flow diverter stents. So, in what cases we used coiling? And results of in this group. So the total occlusion, the complete occlusion, we achieved in 87% of the patient. So it's talk to us that the selection of the patient was correct, because 87% is very high for endovascular surgery. So and subtotal occlusion, Raymond Troy 2, we use Raymond-Troy scale to evaluate the results of treatment of aneurysm. So you may see that we had only one patient, 12.5%. And I think it's not too much. If you are looking to the guidelines, if you you can see that there are no rupture in patients who have subtotal occlusion Raymond-Troy 2. So, but you need to treat them if you see the regrowth of aneurysm. So you need to put stents or coil or flow diverter stents. So I have many options to retreat this patient with minimal surgical risk. So when we use the coils, it's first of all, it depends of localization of aneurysm. So 1A, it's very good localization for coils because you have the straight way for microcatheter. Microcatheter stays stability in aneurysm and in vessel. And so you may put coils without any assistant technique in most of cases. When you have the dome neck rate more than 2, aneurysm size from 3 to 10 millimeters, and very important, the shape and inflexibility of microcatheter. About what I tell, look to this picture. You may see that each localization of aneurysm in ophthalmic segment depend of shape of the microcatheter. If you will take only the straight microcatheter without any pre-shape, or you will try to do it without any assistant technique, so you fall down like I don't know. I can find the word to now, but it will be a big mistake for you. So you need to pre-shape the microcatheter, and it depends from localization of aneurysm in this segment. So, for example, type 1A, you may see the aneurysm, the horizon branch of ophthalmic segment near the aneurysm neck. So in this case, we used only coils, and you may see the complete occlusion of aneurysm. We see the filling of ophthalmic artery. So it's, I think, for my opinion, it's very good result for patient. You don't need to do a very traumatic approach to this aneurysm. So, the first balloon assistant technique we used in 18 patients and 16%. So complete occlusion rate we achieved in 88%. So we can talk that the selection of patient, if we correct select a patient, we can achieve the same results in different groups. So when we use coils, we achieved 87% of this patient. But if we took this 18 patients to treat only with coils, I think the result was very worse. I think only 40% or maybe 30% of complete occlusion we achieved in this group. But when we use the assistant technique, we can achieve the very high result, very high rate of complete occlusion of aneurysm in this patient. And how you may see, we had no Raymond-Troy 3. So we had only subtotal occlusion in 2 patients. It's too low rate, and I think these patients are protected from bleeding or bleeding in post-operation period. So when we used balloon assistant technique, so in the most of the cases of ophthalmic segment, we need to use balloon. First of all, to protect to migration of the loop of coils inside the ICA. And the second is to make the stability of microcatheter in this segment, because we have the tortuosity of artery in this segment, and so we need to fix the microcatheter between the balloon and the wall of the neck to fix it stability inside the aneurysm, and during the implantation of the coil, exclude the migration of my tip of microcatheter from the aneurysm to the artery. So the balloon assistant technique is a very interesting method for treatment patient in this localization. So when we use the balloon, 2A, 2B, it's more simple to catheterize and to put coils when we use the balloon. When we have ratio dome neck, less or the same 2, and when for small size, when we have 3 to 10 millimeters size of an aneurysm. So our result, this is example when we use the balloon. In the left image, you may see the aneurysm without coils, without any items inside the aneurysm. So you can see the 3 markers inside the ICA. So this is markers of balloon, which we put near the neck of aneurysm. So then we in the middle image, you may see that we inflated the balloon. And so during the inflation of balloon, we put a few coils inside the aneurysm. So you know you don't need to deflate the balloon. I think maybe a few months ago, I did a I wrote my opinion to one article in International Neuroradiology for my colleague in Chicago. So, and one of Turkey colleagues compared 2 methods when they deflate the balloon after each coil or when they put coils without deflation of the balloon. So the results without deflation were very interesting and more good than when we deflate the balloon after each coil. And then the right image, you may see that the feeling of ophthalmic artery it's very good, and we don't see the feeling of the aneurysm. So this is good angiographic result, and I think a good clinical result. Stent assistant technique we used in 16 patients, 14%. Complete occlusion rate we achieved in the same numbers, 87%. So this is good result, and this is what about I told you a few minutes ago. We have the same results in all groups. So when we use the stent assistant technique, and this was in 2B type location of aneurysm and the same rate and small size. Size have very influence for result, because when you have the size of an aneurysm more than 10 millimeters, you need to use more coils. It's more expensive for hospital, may have a problem for surgeon, because each coil can rupture the aneurysm during the implantation. So when you treat a patient with aneurysm less than 10 millimeters, you will have the more interesting and more better results. So, for example, another aneurysm when we use stent assistant coils. So in this case, we we use Gilling technique. In the left image, in the left up image, you may see the aneurysm filling. I think this is aneurysm of superior hypophyseal artery. We put microcatheter inside the aneurysm sac, then we put microcatheter inside the ICA. We use Gilling technique to protect the migration of the coils, and so we put a few coils inside the aneurysm, and on the right image you may see that no feeling of aneurysm, and this is a good result. So immediate result and occlusion rate for these types, you may see that Mean rate is 87%. 87% of the patient had complete occlusion rate when we select the patient for coils or different assistant technique. So this is good result. And subtotal occlusion is in 11%. So that means that this patient need to do a control angio. And if they have their growth of aneurysm, you need to treat them, or you may treat them in the second stage using the flow diverter stents or some other assistant technique. So if you want, or you can follow up this patient and treat them only if you have regrowth of this aneurysm. So flow diverters we exclude in that result in the last slide. So because you need a time. Today we need a time from 6 to 12 months to evaluate the results of efficiency of flow diverter stents. So for evaluation, we use the scale of Kelly-Marotta after 6 months. But today I can tell you that 6 months is not enough to evaluate the results. So you need to start to evaluate it after 12 months, and you will have a good results. So after 6 months, we have only 58% of complete occlusion patient after using the flow diverter stent. But this amount grows day by day. When we use flow diverter stents, so you may use stents in any localization. When you have tandem aneurysm, any size, when you have a huge aneurysm or you have the very small aneurysm, so you may treat them using the flow diverter stent. Today, my opinion is that we can use all kind of stents in acute stage of treatment of aneurysm. So, and in my experience, I see very rare re-rupture of aneurysm in acute stage. So, and if you use the coils with flow diverter stents or different kinds of stents, or I never saw re-rupture of aneurysm. So I think that you can treat them and don't afraid to use stents in acute stage. So one of results in the left side, you may see the huge aneurysm of thalamic segment. So, and after using the flow diverter stent, we see the normal vessel. This is like a miracle. Have aneurysm and no aneurysm. So it's very good result. And so all results when we treated the ophthalmic segment aneurysm. So the complete occlusion in mean rate we achieved in 78% of the patient. You may see that the very low rate was in patient with flow diverter stent. We evaluated after I don't see at the top. At the top. So 70% is was a complete occlusion rate after using the flow diverter stent, but this is not finished result, because each day the thrombose inside the aneurysm are going for better and better level. So, and if you see that after 18 months or 24 months, the complete occlusion rate may be 87%, 90%. So you have the one option. You may retrieve this patient using the second flow diverter stent. You may put it inside the first one, and your complete occlusion rate will be higher. So you may use coils, the flow diverter stent, and you may so have the higher rate of occlusion of this aneurysm. So we had, for my opinion, we had very good result. 78% was very good result. Complication. We had ischemic complication in 3 cases. It was 3%. And we, in one case, we had a hemorrhagic complication. It was parenchymal hemorrhage, not associated with aneurysm. It depends of dual aggregated therapy. So the final results you may see here. One patient died. Unfortunately, so in 3 cases, we had worse situation. So MRS 3 and 4. So that results are dependent from our complications. And in conclusion, I want to say that selective approach to choose the method of surgical intervention of aneurysm of the ophthalmic segment of ICA, including the use of coils with or without assistant technique and flow diverter stents on the basis of their topographic and anatomical characteristic can significantly increase the rate of complete occlusion with a minimum frequency of intraoperative complication. The use of balloon-assisted methods makes it possible to increase the packing density with coils and also to achieve more stability position of microcatheter in the aneurysm on this segment. At the same time, the long period, according to the frequency of recanalization, the balloon assistant loses stent assistant method. So the technique of using flow diverter stents have proved to be most effective in treating patients with pathology term maximum radicality and minimum frequency of recanalization. At the same time, it's necessary to take into account of technical difficulties during the implantation of the stent, on which the frequency of complication depends directly. Thank you for your attention, my colleagues.
Thank you so much, Dr. Vitaly, for your nice presentation. We as a young neurosurgeon have to make a lot of notes in order to understand how to manage the patients with endovascular treatment. I have one small question. How long do you follow up your patients after surgery?
Whole life.
For life.
Whole life. We started from 6 months.
Mhm.
And if after 6 months you have the good clinical result, this patient need to do control angiograms each 5 years, because we need to exclude the aneurysm de novo, because the aneurysm, this is not a single lesion of one artery. This is the system disease, so they can appear in different vessels in different parts, so in different bifurcation, in different age, so you need to exclude them, because I think approximately 1.7% of aneurysm de novo we can find after 15 years follow-up.
Thank you. Any questions from the audience?
I don't see any.
If any questions happen, we will come back to them after our third presentation. One more time, thank you very much. And let me move to our last participant today. So, young, ambitious, and brave neurosurgeon from Russia, from Moscow, Ivan Alexeyev, who is a consultant neurosurgeon from National Medical Surgical Pirogov Center. Dr. Ivan Alexeyev graduated from Rostov Medical University. The area of interest are tumors, pharmacoresistant epilepsy, hydrocephalus, trigeminal neuralgia. So today, Dr. Ivan will be talking about treatment of patients with glial tumors of the supplementary motor area. Also, I want to mention that Dr. Alexeyev Ivan is the student of Dr. Andrei Zuyev, who is well-known onconeurosurgeon in Russia as well. So please.
Okay, thank you. Do you hear me?
Yes,
Everything
we can
is
hear
okay
you.
with the sound?
It's
Okay.
fine.
Greetings to all of you, dear colleagues, John and Argiza. Thank you very much for the opportunity to speak here. I and my chief, Professor Zuev, represent Pirogov National Medical and Surgical Center that is located in Moscow. And firstly, I have to apologize that Professor Zuev is not able to take part in our conference right now, but let's hope that he will join us next time. So let me introduce my presentation, surgical treatment of patients with glial tumors of the supplementary motor area. And I was told previously to do it in 20 minutes, so I will try. The supplementary motor area is a cortex region that is located on the medial surface of frontal lobes. Within the interhemispheric fissure, just anterior the precentral gyrus. So why is this cortical region so interesting? Firstly, this is a multifunctional region and it takes part in implementation in many different functions, not only in motor one. For example, the dominant supplementary motor area provides speech and language functions. Secondly, the damage of this area can cause a development of different types of neurological deficit. For example, the damage of this dominant supplementary motor area can cause a development of SMA syndrome, which characterized by the development of contralateral hemiplegia with mutism. And thirdly, any type of neurological deficit can totally regress in the most cases in the period up to several months. So firstly, the borders of the supplementary motor area, the posterior border is the precentral sulcus, the inferior border is the cingulate sulcus, the anterior border is the nominal vertical line that is located 5 centimeters anterior to precentral sulcus, and the superior one is the edge of interhemispheric fissure. This is a heterogeneous region. It has two different subregions, the anterior one, pre-supplementary motor area, and the posterior one, the supplementary motor area proper. The border between these two subregions is the line that goes from anterior commissure and that is perpendicular to AC-PC line. So the SMA syndrome in a neurosem, this is an akinetic mutism, which characterized by contralateral hemiplegia or hemiparesis with a complete or almost complete absence of verbal communication after the damage of the supplementary motor area in dominant hemisphere. In a broad sense, this is any type of motor or speech disorders. And the classic 3-stage SMA syndrome was previously described by Laplane in 1977. The supplementary motor area is supplied with blood from branches of the anterebral cerebral artery, like the medial surface of the precentral gyrus. The increased interest in this region arose in the last 10 years when new white matter tract was firstly discovered and described. I mean the frontal excellent tract that connects the supplementary motor area with the posterior part of inferior frontal gyrus, which coincides in dominant hemisphere with the Broca's area. So the main functions of the frontal excellent tract in dominant hemisphere are speech and language functions. Glial tumors predominate significantly in this area. Here you can see the examples of tumor spreading from the supplementary motor area to adjacent regions. For example, you can see the spreading to the precentral gyrus, to cingulate gyrus, to prefrontal cortex, and the most interesting image is the left bottom one. Here you can see the tumor spreading to the opposite hemisphere through the corpus callosum and to the Broca's area through the frontal excellent tract. So we have provided a retrospective cohort study, which included 40 patients in the study group. All of them had SMA tumors. The largest number of patients had high-grade gliomas. Here you can see the most common symptoms before the operation. There were seizures, motor disorders, memory disorders, and different speech disorders. All patients underwent MRI of the brain before and after the surgery. We investigated low-grade gliomas with the T2 and FLAIR sequences and high-grade glioma with T1 with contrast sequence. Reconstruction of tracts was one of the most important preoperative examination. We were especially interested in the corticospinal tract and in the frontal echelon tract in dominant hemisphere. Here you can see the examples of interactions between the tumor and different white matter tracts. Tumor can push them into different directions, destroy them, or push them apart. Before the encephalotomy was done, we had been performing cortical, speech, and motor mapping. Then we removed tumor through the so-called intravascular windows with the use of ultrasonic aspirator to prevent development of ischemia in the precentral gyrus and in the corticospinal tract. So we tried to preserve all the vessels. Then we performed a subcortical stimulation in order to identify the corticospinal tract and the frontal echelon tract. We removed low-grade gliomas with ultrasonic control and high-grade gliomas with the fluorescent control. Also, we used computer neuronavigation and multivision. So we used all the levels of intraoperative neurophysiological monitoring, such as transcranial stimulation, transcortical stimulation. Here you can see the grid that was located on the precentral gyrus. Direct cortical stimulation. Here you can see the bipolar electrodes and sterile markers that point different areas where we received motor responses, and direct subcortical stimulation. We perform a motor mapping, both cortical and subcortical, with Taniguchi parameters of stimulation. Here you can see the sterile markers that point at different areas where the motor responses from different parts of the body were received, and we used subcortical dynamic stimulation with the dynamic decreasing of strength of stimulus and removing of tumor. So we tried to get as close as possible to the corticospinal tract. We performed a language mapping with the use of Penfield parameters of stimulation. It was previously described that sentence completion tasks and fluency speech tasks were very sensitive to supplementary motor area and to the frontal echelon tract. Here you can see the example of intraoperative speech mapping and during the awake craniotomy. This is another example of awake surgery with the cortical mapping. Patients take part in language tasks for sentence completion. So here you can see the example of sterile markers that point to different speech areas after this cortical mapping. Here you can see the example of subpial resection of tumor. We used ultrasonic aspirator to preserve all vessels, subcortical and cortical, especially vessels of the medial surface of hemisphere. So we tried to prevent the development of ischemia in the corticospinal tract and in the precentral gyrus. So results of our surgery. In 70% of patients, it was achieved a total resection of tumor, but 55% of patients had a deterioration of neurological status in the early post-operative period. But any type of neurological deficit, both motor and speech, in the most cases have totally regressed in the period up to 6 months. Not in all of the cases the total resection of tumor was achievable. Here you can see on the middle image the example of residual fragment of tumor in the precentral gyrus, and on the right picture you can see the residual fragments of tumor in the area where the frontal echelon tract began. Reconstruction of corticospinal tract after the surgery was very useful examination in doubtful cases when patients have developed a motor deficit after our operation. And we tried to compare the state of the corticospinal tract before and after the surgery. So we tried to prove that the corticospinal tract is still intact, and the motor deficit is caused by the damage, exactly by the damage of the supplementary motor area, and not by the damage of the corticospinal tract and precentral gyrus. So I will show you some clinical cases. The first one, woman, 39-year-old, with a low-grade glioma in the supplementary motor area. We performed a total resection of tumor, and she had no neurological deficit after the operation. 1 year after surgery, you can see a nice neuroimaging results. The second case, 31-year-old man, also with low-grade gliomas, but in this case, we performed a subtotal resection of tumor, and you can see the residual fragments in the precentral gyrus, and we have stopped intraoperatively at strengths of stimulus of 4 milliamperes. This patient also had no neurological deficit after the operation. 33-year-old woman with a giant glioma that was spreading to the opposite hemisphere through the corpus callosum. Here we performed a subtotal resection of tumor. We stopped at 2 milliamperes, close to the corticospinal tract. But unfortunately, this patient developed SMA syndrome. I remind you that this is akinetic mutism, so she had no movements in the contralateral extremities, and it was complete absence of verbal communication with her. But 2 months after, you can see that she almost had no motor disorders, and she had nice speech, and she can speak and read. And the last case, 61-year-old man with a high-grade glioma in the supplementary motor area. We performed close to total resection of tumor. We stopped intraoperatively at 1 milliampere, close to corticospinal tract, but unfortunately he has also developed SMA syndrome. 2 weeks after operation, you can see the movements in the distal part of the leg appeared, and 2 months after the operation, he was able to walk normally. The video is not going for some reason. We try to analyze the influence of different parameters to development of postoperative deficit. So the tumor volume, the resection of the posterior part of the supplementary motor area, and the resection of the middle third of cingulate gyrus were statistically significant factors in the development of postoperative motor neurological deficit. Distance to the frontal S1 tract less than 2 millimeters was statistically significant in impaired initiation, fluency of speech disturbances, or stuttering. Resection of the SMA proper with the middle third of cingulate gyrus was statistically significant in the development of mutism and motor or sensorimotor aphasia. So we had 22 patients with the SMA tumors in dominant hemisphere. First time we performed awake surgery with speech mapping and language tasking in this group of patients. But after the time, we realized that any type of deficit, speech deficit, can, in the most cases, totally regress in the period up to several months. So we tried to perform this surgery in this group of patients, and we had 2 groups with the same number of patients. And the statistical analysis showed that this factor, I mean, intraoperative speech mapping during the awake craniotomy, is not statistically significant factor in the development of speech disorders after the operations in this group of patients. So the take-home message is the supplementary motor area is multifunctional regional. It's a heterogeneous region. Neurosurgeon should pay attention to preoperative talk with patient and his relatives. He should tell about the opportunity of development of such neurological deficit like the supplementary motor area syndrome, and that this syndrome can totally regress in the period up to several months. And you should use all the levels of neurophysiological monitoring in such group of patients to prevent damage of the corticospinal tract and presentral gyrus. So I am with a great pleasure referring all of you and all people who are interested in this topic to our previous articles. Thank you for your attention.
Dr. Alexey, thank you very much for interesting case presentation, for interesting information which you have given to us. I just wanted to add that yes, talking with patient and relative, it is very important preoperatively, but the most important, I guess, is the teamwork which decide how to go, when to go, and what not to do sometimes. So neurophysiologists and later on neuroradiologists, chemotherapists. So this group of people are also very helpful for us as for neurosurgeons.
Okay, yeah, thank you. It's a very important teamwork is very important in these cases.
Yes, thank you. I'm really impressed with today's presentations, and I'm very glad that we already started, and I hope that next time we will be growing, we will be getting more audience. But anyway, today we got 20 participants, and it's already a very big amount of people who are ready to listen. So our main aim is to show that Russia is one of these countries who can do so many surgeries, and we have the things to show to world, and we have to speak about that. We have to talk, and do not hesitate about our experience. So this is the most important message I would like to take today.
Well, Nargiva, that was excellent. A lot of enthusiasm, a lot of people. It's a great start. It's an excellent start. I'd like to thank all the participants for coming. It's a great platform made for a country like Russia that's so huge. You can tie the whole country together with Zoom easily. We just have to arrange it. And
I just wanted to add that, only in Russia you have this unique system like federal neurosurgical centers. It's particularly just neurosurgical hospitals where you have only, brain pathology, brain and spine pathology. And, the people who are gathered in this place, they can have so many interesting ideas about treating the patient, following up. This is the best place to learn, and I have started my residency back in 2018. It was exactly in a big neurosurgical center in Siberia. So this is important, and I highly recommend people from different countries, please do visit Russia. There are a lot of interesting cases and intelligent people you can meet there.
We hope to find out a lot of cases, and if we could, is the federal center one of those centers you're talking about in Tyumen? Is that one of those centers?
There is a federal center in Tyumen, in Novosibirsk, in Russia, Moscow, in Burdenka, in St. Petersburg, and apart from that, there are small centers like Stroke Institute, Pirogov Surgical Center, and others as well.
Well, we can all learn from each other. It'd be nice to tie those centers together, and we'll work on that.
Yes, we will.
Okay, very good. Okay, thank you everyone very much.
Just 1 second. We left one question. Okay, I have to.
Yeah, go ahead.
1 second. Okay, from Taha Zaid, there was a question to Dr. Andrei Dubovoi. What the most obstacles you face in during aneurysm cases? So, what are the most obstacles?
Oh, it's a very philosophic question because because all stages of aneurysm surgery is all stages are difficult, I think, but more difficult for me. Sometimes I need to detach a small artery branch from the aneurysmal dome. Sometimes the branches of the small arteries is very strongly attached to the very thin aneurysmal dome, and without detaching this small branch, sometimes it's impossible to clip the neck of the aneurysm, and the surgeon need to carefully, step by step, detaching this small arterial branch from the aneurysmal wall. For me, this is a more difficult stage for in aneurysm surgery, I think.
Mm-hmm. Thank you so much. We have one more question for Dr. Alexey. The question is, what can you say about the relapse of patients with gliomas grade 3 and more in your practice?
Okay, thank you very much for the question. This is a very important one. So patients with high-grade gliomas, of course, had very often relapses of tumor, and of course, you can see about the total resection of tumor in these cases. Of course, after the surgery, there are a lot of cells, of tumor cells, and it is very important that after our surgery, patient can go by themselves to further treatment, I mean chemotherapy and radiation therapy. And there is a problem in Russia if patient had low performance scale and Karnofsky scale after the operation. He had no opportunity to have a chemotherapy and radiation therapy after the surgery. And the SMA syndrome is a reversible syndrome, and of course, after 2 months, patient can have this treatment, I mean the chemotherapy and radiation therapy.
Thank you so much. Thanks a lot from Dr. Ilya Molchanov. So,
okay. Do we have anything else? Because I'd like to close it up if we could. Before we go, Nargiza, I'd like to show the audience what we have coming up.
Yes, just after a few minutes, we will have the China Neurosurgical Journal webcast.
Yes, we have that in about an hour. It's going to be live on Neurosurgical TV. And Nargiza needs the rest. She's done a lot of work getting this together. So don't worry. Thank you. Did a great job.
Yes, also all video will be saved on YouTube. So whoever wants to look to see it on repeat, you are most welcome to go to the main website or to the YouTube channel and just have a look.
Either channel. So, okay, everyone, over to China.
Thank you so much. Bye-bye. See you.
Thank you. Bye. Bye.
Thank you.
Thank you. Goodbye.
Thank you. Bye-bye.